On Thursday, September 23rd, 1937, President Franklin Delano Roosevelt announced the impending launch of a new organization, the National Foundation for Infantile Paralysis, which was officially born January 3rd, 1938. It later became known as March of Dimes. This fact is, for the most part, widely known. But what many may not know is that there was another man deeply invested in the founding of the organization and in ending polio. That man was Basil O'Connor, FDR's closest legal advisor and March of Dimes' first chairman and president. So instrumental was Basil O'Connor to March of Dimes that the organization named one of its most important research grants after him. The Basil O'Connor Starter Scholar Research Awards, which were first awarded in 1973, the year after he died, are the organization's signature grants for up-and-coming scientists embarking on lifelong research paths. Previous winners have gone on to have remarkably successful careers in science and medicine. These winners include Dr. Diana Bianchi, director of the Eunice Kennedy Shriver National Institute of Child Health and Human Development, Dr. Ardem Patapoutian, a Scripps research neuroscientist and Nobel Prize winner, Dr. David Julius, a University of California physiologist and Nobel Prize winner, Dr. Craig Mello, a University of Massachusetts biologist and Nobel Prize winner, Dr. Peter Agri, a Johns Hopkins biological chemistry professor and Nobel Prize winner, Dr. Francis Collins, a physician scientist who is the former director of the National Institutes of Health, Dr. Juan Carlos Izpizua Belmonte, a world-renowned developmental biologist at Altos Labs, Dr. Alexander Rajkovic, a University of California, San Francisco pathologist who was part of the March of Dimes Prematurity Research Center at UCSF, and Dr. Sing Sing Wei, an infectious disease pediatrics professor at Cincinnati Children's Hospital and the lead investigator of the March of Dimes Ohio Collaborative PRC. Now in its 51st year, this grant is the vessel to conduct translational research that propels the development of therapeutics, diagnostics, and interventions from the laboratory into the clinic and helps change the lives of mothers and babies for the better. You can think of it as March of Dimes' Scientists to Watch Awards. Winners often propose fascinating areas of study and go on to make a lasting impact on science. This year's winners are no exception to that tradition. Let's meet these women to watch right now.
The views expressed on this podcast may not represent those of March of Dimes or its staff. Information presented on this podcast is not medical advice and should not be construed as such. When in doubt, seek competent medical advice. Now, on with the show.
Dr. Elizabeth Enninga is an assistant professor of obstetrics and gynecology and immunology at Minnesota's Mayo Clinic. Dr. Murray Horwitz is a primary care doctor at Boston Medical Center and an assistant professor of medicine at Boston University. Elizabeth joins us from Minnesota and Mara joins us from Massachusetts. Elizabeth, welcome to the show.
Thanks for having me.
Mara, thank you for coming on.
Thanks for having me too.
Elizabeth, you'll be using your Basil O'Connor Award, a $150,000 award over a 2-year period, to study the role of cell-free fetal DNA on labor and preterm birth. Mara, you'll be using your award to study barriers women with a hypertensive disorder of pregnancy, also called HDP for short, the acronym, like preeclampsia, face in achieving cardiac and overall health after childbirth. While these are two different topics, they tackle two leading complications facing American mothers, preterm birth and preeclampsia. Elizabeth, let's start with you. You are studying cell-free fetal DNA and its ability to trigger labor. Knowing more about this type of DNA could allow doctors and scientists like yourself to one day create a test that could identify women at risk of delivering early and offer them targeted therapies that could delay or prevent preterm labor. First, how long have you been passionate about this topic and researching it?
So I actually started working on this topic and wondering about why cell-free fetal DNA is being released into a mother's circulation as a postdoc in 2018. And during that time, most people were really interested in cell-free DNA as a non-invasive screening test, really for identifying a fetus that has trisomies like Down syndrome from the maternal blood, and instead of utilizing these more invasive procedures like an amniocentesis. However, no one was really asking about the biology. Like, why is this happening, as our bodies really don't tend to do things just for the heck of it. So I really wanted to understand this biology and how these fetal derived DNA fragments were potentially interacting with the maternal system.
So, skipping over a couple questions here, what did you find for why this is being released into the bloodstream?
So cell-free fetal DNA is released into the maternal bloodstream through the normal process of syncytialization. So syncytialization is where trophoblast cells of the placenta become syncytialized. So they actually go from one single cell to a giant multinuclear cell called a syncytiotrophoblast. And that syncytiotrophoblast in the placenta is what directly communicates and interacts with the maternal blood. And so during that process of becoming these multinuclear cells that have direct contact with maternal blood, they release DNA into the bloodstream. And then that DNA is what circulates throughout the mother.
And so is the only purpose then to initiate labor of this cell-free fetal DNA, and also to tell doctors and mothers whether the baby is healthy through these screening tests that you mentioned in the beginning?
So that's something that we really want to try and address. Like, could that be the reason that this DNA is shed? We do know that the DNA increases throughout pregnancy, and this is probably because of the fact that the placenta and the fetus, and therefore the fetus, are growing throughout pregnancy. So as you get a bigger and bigger placenta, you're releasing more and more DNA. And so by the time pregnancy, like the third trimester, late pregnancy is occurring, oftentimes you can have as much as 15% of the maternal DNA that's circulating that actually comes from the fetus, which is crazy. There's no other process that I can think of where if you had 15% of a foreign thing in your body, you would not have some sort of terrible sickness. And so we are really interested in trying to understand, in preterm birth, does this release of DNA actually happen much earlier? And therefore, there's a response that's generated before pregnancy is over, so before term.
Okay, so we don't yet know whether this cell-free fetal DNA reaches that fever pitch right before birth in women who give birth early.
So there are clinical studies out there that have demonstrated that women who have non-invasive prenatal screening done during their second trimester that have higher concentrations of cell-free fetal DNA are more likely to end up having a preterm birth. So this is more of a, thousands of patients. We retrospectively look back and we see that those women that had higher concentrations of cell-free fetal DNA in the second trimester were more likely to have a preterm birth. So that's really where our hypothesis came from, and why we really want to understand this biology to see if this could actually be one of those mechanisms that promotes labor.
Yeah, absolutely. It seems like it's a very promising road to go down. So you mentioned that we're still trying to figure out exactly why the placenta secretes this DNA, but we know that it does, and we know that it increases as pregnancy goes on, likely because of the size of the placenta. And tell me what we know now about cell-free fetal's DNA role in initiating labor and in the immune response that the mother experiences that ultimately initiates labor.
Yeah, so my group has been very interested in this topic. There's been a few other groups also kind of dabbling in this as well. But what we've been researching is the role of which immune cell specifically is being activated by these cell-free fetal DNA fragments. So what we've been finding is that the maternal monocytes specifically, so this population of innate immune cells, are really important for having the ability to see the DNA, process it in a way that it leads to inflammatory signals that are released. Those inflammatory signals, what we've found is they will actually activate other immune cells, which will amplify an immune response. And then they can also work on amplifying responses in the uterus and for endothelial activation. Endothelial activation, very important for getting inflammatory cells to the uterus like we see it during labor. And then, contractions are a very hallmark of labor. So we see that these inflammatory responses that are generated by monocytes responding to cell-free fetal DNA can activate and induce these two key hallmark processes of labor to occur.
A little bit of a tangent here. A question about preeclampsia, not for Mara, but for you, Elizabeth.
Sure.
I interviewed a woman on this podcast named Mara Mufaraj, and she's a leader in preeclampsia research. Actually, she's going to be in a PBS documentary in the next couple of days. I saw on LinkedIn, something called Pathways to Discovery or something like this. But one word that she kept two words that she kept mentioning during her interview about preeclampsia and what we know about it, which, by the way, not much. The answer is not much. She kept saying endothelial cells. And you just said endothelial cells. And is there any way perhaps cell-free fetal DNA and endothelial cells are related, and maybe this work that you're doing could somehow dovetail with preeclampsia research?
I mean, that would be really exciting. We do know that women that have pregnancy complications, such as preeclampsia, actually do end up having more cell-free fetal DNA in their bloodstream as well. And it's probably because their placentas are stressed, right? Some of the hallmarks of preeclampsia, and it's really a multifaceted disease, which I'm sure Mara will speak more about. But, one of the symptoms is your placenta has poor spiral artery remodeling, and therefore blood from the mom isn't getting into the placenta and, perfusing that placenta the way it needs to. And therefore, the placenta is likely undergoing more stress and releasing more DNA. So there's certainly some similar mechanisms between whether or not the cell-free DNA could potentially also be predictive of preeclampsia and help us in understanding, the biology behind this really devastating but equally confusing pregnancy complication.
Yeah, absolutely. And so is cell-free fetal DNA the main precursor of inflammation that leads then to preterm birth, or are there other pathways and events that happen unrelated to cell-free DNA that also target those monocyte cells that then begin that cascade effect?
I mean, a lot of things could potentially, right? Infection, moms get sick during pregnancy, that can increase inflammatory responses. The microbiome also releases things that can be inflammatory and cause responses. So I think this is probably, if this were simple and one, like if I could tell you that cell-free fetal DNA was the thing that caused labor, like someone way smarter than me would have figured this out a long time ago. And so it's going to be a multifaceted thing that where, the immune system is working tangentially with other parts of the body in order to orchestrate this, grand finale of the labor process.
But it sounds like cell-free fetal DNA is the only kind of natural, non-pathological, non-illness related thing that triggers immunity, right? Because the microbiome, that's bad bacteria in the vagina, and an illness is bad as well. But this seems to be like the normal way that spontaneous labor happens is through cell-free DNA. Would you agree with that?
Well, I don't want to say that. Yes, I don't want to say it's the only thing. Yeah, it might be too early to say it's the only thing. But yes, all of our data thus far suggests that this has a really profound effect on promotion of normal labor. And I think one of the best things we can do right now in 2024 is really define what is normal labor. What's the biology behind that? It's pretty incredible to me that we still don't know the answer to that question. And therefore, I think all of our attempts at preventing preterm labor have really not gone as far as we would have liked them to, because again, goes back to the biology. What's the biology? Understand that biology, then we can actually target treatments, preventative strategies, and predictive tests that will help us address this.
Absolutely. So speaking of predictive tests, you are interested in thinking about this as well. It's part of the work that you're doing with the Basil O'Connor grant. And theoretically, what would a test look like? It would measure two elements in the blood, right? Of the maternal blood, the cell-free fetal DNA and monocytes, right? And if both of those were kind of skyrocketing, then we could maybe assume that a woman is nearing labor. Is that right?
Yeah, as part of the award, we really want to look at the activation of monocytes, because we don't, monocytes themselves, I don't think will be enough to really tell us that we have or do not have a labor type immune response. But if we could look to see if certain activation of these monocytes has occurred, I think that would really be key in understanding which pregnancies are at risk of this preterm birth phenotype. The other thing, as you mentioned, is the cell-free fetal DNA itself. We already have a clinical test that looks at this early in pregnancy. And so just utilizing that, I guess, stage later in pregnancy might actually help us do this more rapidly and, not have to wait years and years and years for a brand new test that could tell us exactly who might be at risk of developing preterm labor.
Yeah. My next question is about how simple a test like this would be to develop, and you kind of just answered it, right? You just kind of shift the cell-free fetal DNA test, or you add another one. There's the beginning, and then you add one to the end of pregnancy, and then monocyte activity, that's just a simple blood test, right?
Yep, you could do a blood test, and then for a lot of, simple is a difficult question clinically, but like the idea would be a blood test with potentially some flow cytometry, which is a method that looks specifically at different cell types in your blood and can highlight the phenotypes and then quickly define what might be normal or abnormal in these cells. And so, both of these have been utilized clinically. And so it would just be a matter of repurposing them, I guess, in a way to address preterm birth.
Yeah. And so we know that with natural preterm labor, you can delay it a little bit, not much, but science has allowed doctors to delay it maybe a couple days, maybe a couple weeks. What is it possible to delay it? Is it possible this process stops naturally and kind of reverses itself, or once it starts, the cell-free fetal DNA increasing concentrations and the monocyte activity as well, that labor is quite imminent? Or is it possible that something happens in the body that says, hold it right there, we're not ready yet, or whatever?
Yeah, I mean, I think it would be possible. It's just a matter of identifying who would be, needing said treatment or with some sort of helpful test. So, immune responses, you can certainly modify those. It's with all sorts of different anti-immune agents out there. There's tons and tons of things that block cytokines, that block inflammatory processes. And so, just taking what we already have and potentially trying to apply it in situations where, you do have a preterm labor case occurring and you need something, right? This could be possible. And so we do hope to try and get at that question a little bit more clearly to see if we activate the cells, can we actually utilize different targets of that activation pathway to slow down that activation and potentially stop it altogether.
Right. I was speaking to another researcher on this podcast, and he's an anesthesiologist that does a lot of work with machine learning, and so they created a model that can predict preeclampsia, labor onset preterm birth, but also identify the exact biomarkers and what behind those predictions. And one of the biomarkers that he identified was a receptor called IL-33. You're probably familiar with it, Elizabeth, and they're using drug repurposing also to be able to get at this receptor. But he told me that monocytes, so you might want to stop that monocyte activity that leads to preterm birth, but you don't want to stop all monocyte activity because monocytes are actually very important for other reasons. And so this is the trickiness in using drug repurposing. And I wanted to see if you could talk a little bit about, how your team is going to get at this issue of potentially creating or adding to the science that creates a medication for preterm birth, knowing what we know about cell-free fetal DNA, or what you will help us understand.
Yeah, you're spot on. I mean, the immune system is complicated and we need it, right? You can't just block your entire immune system and hope for a good response. That won't end well for anyone. So, I do think we'd have to kind of think about risk benefit, and then if there are ways to target certain types. So there are different methods that are actually used for delivering like chemotherapies to tumors without having them impact other areas. So, could we come up with some sort of drug that might be able to target itself to potentially like the uterus, or target itself to someplace where inflammation is occurring and it's occurring too soon, and that might be able to help us actually deliver the best drugs to the right spot in the body, and not have all the other conditions that might be bad to be blocking for some other reason somewhere else. So that would be my hope, is that at some point we get to an idea where, or we get to a point where we can actually specifically target these drugs and these therapies to areas that are in need of stopping inflammation, and not to other areas where you do need the inflammation.
Yeah. And the majority of this discussion with you so far has been about how we can use what we know, what you are discovering about cell-free fetal DNA to stop birth, because it's preterm birth. And we know that the longer a baby is gestating, the better it is for mother and baby. You're also interested, though, in activating labor, not stopping labor, but the opposite, activating it more effectively using this same line of research, cell-free fetal DNA. Can you talk to us a little bit about that and why it's important to more accurately, more effectively induce labor?
Yeah. So, right now, one of our methods for inducing labor is Pitocin. And Pitocin really works by stimulating uterine contractions once your cervix is dilated. But it really doesn't do anything else in regards to promoting this systemic inflammatory response that we also see at the end of spontaneous, or when spontaneous labor is generated. And this is where we think potentially some fetal DNA type of mimic might be useful in order to promote the labor process more naturally. And so, we're looking for, as part of the grant, we're actually looking for these more shared sequences and epigenetics that are specific of cell-free fetal DNA, which, along with concentration, may be really important for promoting this inflammatory response that precedes labor. And that would be, very useful for the fact that, there are a lot of women that have to undergo inductions, and about 20% of those inductions end up failing. And we do know that those women that are induced are about 2.5 times more likely to have a C-section. And, C-section comes with its own risks for the mother. So many patients may shy away from inductions just because of that risk. But you also mentioned stillbirth. The risk of stillbirth after 32 weeks of gestation increases with gestational age. And so going past term actually can
42
greatly.
weeks?
Yep. So going, past term, or, at 40, going 40 weeks beyond can really increase your chances of stillbirth. And that is something we also want to prevent. So we're really hopeful that there's a possibility that in understanding the cell-free fetal DNA in labor, we actually can, go with the prevention of preterm birth, because that's really important, but also potentially help these women that are having to undergo an induction have a more successful induction.
Right. So what you're saying is that Pitocin is not effective enough. And so if we can create a cell-free fetal DNA mimic that we can add to the Pitocin regimen inside the hospital, inductions will be more successful, cesarean births will decrease, and women will not fear inductions the way they do now, because they know of that link with cesareans, and they will be less likely to go past term, which can lead to stillbirth.
Absolutely. That would be the entire goal, is to really improve the general feel of inductions, because there's right now a large group of people who are very adamant that that is not the way to go. And we really do want to help women have the best birth process ever.
Elizabeth, do you think that you are working on this mimic, correct? And you're interested in working on the mimic, or is that just something that's kind of out there in the scientific ether and you know about it, or are you directly going to be working on it?
Well, we are working on trying to define that cell-free DNA in a way that would be useful for then designing a mimic of some sort that would
Mm-hmm.
be more like the cell-free fetal DNA that you would get naturally in your bloodstream. So, we're still probably a decade at least off from there, but it is something that, as we think about defining mechanisms, the biologic mechanism between spontaneous labor or behind spontaneous labor, we do think about the how to prevent preterm birth and how to promote better labor responses.
Wonderful. And just kind of a clarifying question about everything we've talked about today. So as kind of a non-scientist, I've heard a lot of people say, it's an immune response that leads to labor, natural, healthy labor, an immune response. And so this is something we've known for a long time, but is it the cell-free fetal DNA piece triggering that immune response that is new and that your team is working on? Is that right?
Yes, yeah, we're trying to figure out, because we know the end of labor is highly inflammatory, and we know moms have high levels of these inflammatory cytokines in their blood, but we don't know why. And so we're really trying to understand, the labor process from the lens of the immune system, and the role of cell-free fetal DNA in that ability to induce immune responses, may turn out to be really useful.
Yeah, very cool. Extremely groundbreaking. You have a lot of work ahead of you in terms of the mimic and the preterm birth test and continuing to understand the biology of normal labor. So congratulations again.
Thank you to the March of Dimes. We're really excited to get working on this.
That's Dr. Elizabeth Enninga, an assistant professor of obstetrics and gynecology and immunology at Minnesota's Mayo Clinic. Mara, you have been listening patiently. Thank you so much. How are you?
I'm good, thanks. Thanks for having me.
Of course. Elizabeth and I had a background call before. That's how I got to know her, in a background call. But Mara, you and I got to know each other intimately through email. And I could see that you are passionate, truly, truly passionate about helping women with previous hypertensive disorders of pregnancy access primary care following their births. How long have you been researching this topic?
I've been researching sort of reproductive and sexual health for a while, but really focused on postpartum care about 7 years ago, which is when I had my first child, which is not a coincidence, because sort of going through the postpartum period myself was what really opened up my eyes to what a challenging, high risk, but also sort of ripe for improvement time it is in a person's life.
Yeah, absolutely. And just very quickly, Elizabeth, I want to say congratulations on the birth of your son. I forgot to say so at the beginning of the episode, but Mara talking about her 7-year-old, her firstborn, that influenced her work and inspired her, made me think of your son. So congratulations again. You are newly postpartum, right? 6 weeks, 8 weeks, 12 weeks?
I think we're at 11 weeks now, almost a 3-monther. 3-month-old little guy, and it's been a process. And Mara, I completely agree. When I saw how you're going to do what you're researching, I was all excited about this, because I would say that 4th trimester that some people call the postpartum period.
The farther out I get from pregnancy, the more trimesters I add. I think there's the 4th and then there's the 5th, and I don't know what trimester I'm in now, but it's I think it's a much longer process than people may realize. And I think part of the problem is that a lot of that postpartum transition really happens in the shadows. People aren't accessing healthcare. They're at home. They're awake when everybody else is asleep. And I think there's also, going off on a tangent here, but I think there's quite a bit of stigma around having a hard time postpartum as well, because there's, I would say until recently, a lot of like social media and public messaging about people thriving postpartum and just like having the best time with their baby and, napping when the baby naps and catching up on books and things like that. But I think the reality is it's a really hard time for a lot of people. And if it's not going smoothly for you, sometimes you're made to feel like that's abnormal. But I actually think having a hard time postpartum is normal. And trying to sort of shed more light on this postpartum experience and hopefully come up with, like high level solutions to make this easier for most people.
Yeah, absolutely. I saw Elizabeth laugh, Mara, when you said sleep when the baby sleeps. That's the funniest thing in the world. Like, yes, we're exhausted, but we cannot just fall asleep when somebody snaps their fingers, And there's other things that need to be done in the house.
Well, the best advice I heard was sort of an extension of that. It was sleep when the baby sleeps and clean when the baby cleans.
I love that. Yeah.
I appreciate the second part of it because suddenly, it's okay, that's something I can do.
So talking about HDP, hypertensive disorders of pregnancy, what conditions what conditions are included in this umbrella? Most people have probably heard of preeclampsia. I guess the second most severe one, right? Because the most severe one would be eclampsia.
Mm-hmm.
Is that right?
Yeah, so it is, like you said, it's an umbrella term. There are a lot of conditions within it. I would say there are 3 major ones, and then there are some areas of overlap or like progression. So there's preeclampsia and gestational hypertension, and both of those are conditions that are diagnosed during pregnancy, specifically in the second half of pregnancy, and they're really thought to be induced by the pregnancy. And then there's chronic hypertension, which is either a condition that you had coming into the pregnancy or that was diagnosed in the first half of the pregnancy, which could indicate that you actually had pre-pregnancy hypertension, but it wasn't recognized until you got engaged in pregnancy care. So those are the 3 main conditions: preeclampsia, gestational hypertension, and chronic hypertension. And then, like I said, there's overlap. So a person with chronic hypertension can then develop superimposed preeclampsia, which involves signs of end organ damage, like proteinuria during the pregnancy. And then, like you indicated, preeclampsia itself can progress to eclampsia.
What is the difference between preeclampsia, I guess, between all 3 of those pregnancy conditions? Chronic, hypertension of pregnancy, or just gestational hypertension, and preeclampsia. What are the differences there?
Yeah, so I talked about the differences in terms of timing of diagnosis.
Yes.
So chronic hypertension really is just based on elevated blood pressures.
Mm-hmm.
So if you have 2 elevated blood pressures, essentially indicating that your blood pressure consistently elevated on different visits, then you have chronic hypertension. Gestational hypertension is actually, has the same clinical criteria of just 2 elevated blood pressures on different occasions, but it's diagnosed in the second half of pregnancy. Preeclampsia involves not just elevated blood pressure, but also signs of end organ damage. So this person is showing that high blood pressure is having some effect on other organs in the body. For example, like I said, the kidneys leaking protein into the urine, or the liver becoming inflamed, or in its most severe form, can start to have some cognitive impact. So you can start to see changes with mentation. And if it actually results in seizures, then that person has eclampsia.
How common are hypertensive disorders of pregnancy? Is this something that is quite rare or quite common? Is it becoming more common?
Mm. It is both quite common and becoming more common. So it's, if you look at all deliveries, so all pregnancies that result in a delivery, it looks like between 10 and 15% of them are affected by a hypertensive disorder of pregnancy. And there's possibility of overestimation or underestimation, like you said. My guess is overall, probably we need to worry more about underdiagnosis than overdiagnosis of these conditions. Within certain population groups, the prevalence is higher. So if you have a 10 to 15 prevalence in the general population in the US, you've got about a 20% prevalence among women who identify as Black or Native American. Older women are also more likely to have it, and people with low incomes are more likely to have a hypertensive disorder of pregnancy. And the numbers are increasing, we think, because more and more older women are giving birth. And so, I think the prevalence just a few years ago was closer to 10%, and it's creeping up now.
Wow. And your focus is making sure that women that have had hypertensive disorders during pregnancy have access to good primary care after pregnancy, so that they can have good heart and overall health. What is the relationship between hypertensive disorders of pregnancy and heart health later in life, or in general, heart health? How is the heart impacted by these types of conditions?
Yeah, so they are considered sort of indicators of future heart disease risk. So they are one of the earliest signs that a person is more likely than their counterparts to develop heart disease in the next 10, 15, 20 years. The associated risk is about 2 to 3-fold, depending on the type of hypertensive disorder of pregnancy. And I will mention having a preterm delivery is a similar risk indicator for future heart disease. If you follow a person with a hypertensive disorder of pregnancy over time and compare them to somebody who had a normotensive pregnancy, you'll see that they're more likely to develop like traditional heart disease risk factors as time goes on. So they're more likely to develop chronic hypertension, more likely to have obesity or hyperlipidemia or high cholesterol. And those are, of course, risk factors for heart disease, but they actually don't explain 100% the association between hypertensive disorders of pregnancy and heart disease. So there's some additional information there, beyond what we could ever hope to obtain just from our traditional heart disease screening. The other thing that I think is really powerful about them is that they give us earlier information. So these sort of red flags go up during a pregnancy in a typically pretty young person who doesn't yet have chronic hypertension or high cholesterol or obesity. So it's not only additional information, but it's earlier information. And for that reason, pregnancy has been called a natural stress test for the heart. And so I like to think about this, as a primary care doctor, what do we do when someone has a positive stress test? We immediately start to screen them for risk factors and try to manage their risk. And we're quite aggressive about it. And the funny thing is that we don't act that way after someone has had a positive stress test in pregnancy, with the diagnosis of preeclampsia. It's often, not asked about in primary care visits or not well documented in the chart, certainly not carried forward in notes from pregnancy-based care to primary care. Patients often lack information about what it means for their heart health. And it's often not followed by the same aggressive risk screening, counseling, and management that we would do after another stress test. So it really feels like a missed opportunity. 80% of women are going to experience a pregnancy at some point in their lives. 10 to 15% of them will probably have a hypertensive disorder of pregnancy. And so there's all this free information from these natural stress tests that are, coming back positive that I would like us to use more in primary care.
Yeah. And you just mentioned the missed opportunity, everything that is not being done now that could be done. Are those the main challenges and barriers that you're trying to tackle, or is the main barrier the fact that there are plenty of women with previous HDPs who are just simply not getting primary care at all? They're not seeing a primary care physician.
Yeah. So many of them are not seeing a primary care clinician. That's true. So it looks like about 50% of people connect with primary care in the year after a hypertensive disorder of pregnancy, 50 to 60%. The recommendation is that they all connect with a continuity provider and that they get comprehensive cardiovascular disease risk screening and counseling and management within the first postpartum year. So we're falling short in terms of linkage to primary care. But as you indicated, there are so many steps along the way to it, to even getting to primary care. And what I found is as I sort of plot that journey that the patient has to take from, being pregnant and delivering to then finding their way to primary care, at every step along the way, I'm finding barriers. And so what I'm hoping to do with my research, like I said, is one, shed light on the patient experience and the barriers that exist, but then also really try to prioritize them and come up with some health system intervention to address them.
Yeah. Can you talk about some of those barriers before we even get to the doctor's office, if we get to the doctor's office, right? Like I have here in my script, money, language, childcare, transportation, insurance, depression. These all come from a previous conversation we've had. So maybe just talk us through some of these things that just prevent us from seeing the doctor to even try to help us, try to manage.
Yeah. So you've mentioned a ton of really important barriers. Let me see if I can address them sort of one by one. So childcare. So people say that both not having adequate childcare for example, like not being able to find a daycare for their child is a barrier. But then also just living with a baby, figuring out how you're going to, support this new life and look after yourself is really hard. And time and again, postpartum people, new moms are telling us that they put the baby first. And newborns, infants can be very demanding, and that doesn't leave a lot of time for the person to look after themselves. Transportation, again, a lot of people lack adequate transportation. You throw a baby into the mix who needs a car seat and, has strict nap schedules or unpredictable naps. I mean, it's, again, making it much more challenging. Insurance is a really huge one. So unfortunately, a lot of people only qualify for public insurance due to a pregnancy. And if you have pregnancy-based insurance, and you're in a state that has an expanded Medicaid, you're going to lose that insurance after 60 days postpartum. And so a lot of people really fall off of a cliff in terms of insurance, when they're postpartum, in the midst of so many changes and also so many sort of healthcare threads that, that haven't been tied up yet. And that makes it, very difficult and costly to access healthcare.
You mentioned that Black women and Native American women have higher instances of hypertensive disorders of pregnancy. Are they also more at risk of falling through the cracks here with all the barriers that we mentioned, from money to insurance to childcare to not being able to find a doctor at all?
Yeah. So it sort of becomes like a perfect storm situation. Take a Black woman who had a hypertensive disorder of pregnancy. She's more likely not only to have the hypertensive disorder of pregnancy, but more likely to have a severe hypertensive disorder of pregnancy when compared with a white woman. Postpartum, she is less likely to connect to primary care. And part of that may be because she's also more likely to have public insurance and to have a low income. So, there's, I think, all the same factors, or many of the factors that are predisposing people to hypertensive disorders of pregnancy, like sort of chronic stress, racism, having like limited access to healthcare. They're also making people less likely to be able to access primary care.
Yeah. And so the big question is here, what are we going to do about it? And Mara, what are you going to do about it? Your goal is to conduct a randomized control trial, an RCT, which the pilot will begin in 2027, where you see patients, Boston Medical Center. And the pilot will test a particular intervention. So something or someone that can close these gaps and fill in these cracks. It is called patient navigation. Can you talk a little bit about this?
Yeah, so patient navigation is, I guess the goal of patient navigation is to help individuals who are at high risk for poor outcomes to access the care that they need. And it involves, 4 main steps. So the first one is to identify your group that is at high risk for poor outcomes. In the context of this conversation, that could be women with low incomes, or women who are minoritized or otherwise structurally marginalized, who had a hypertensive disorder of pregnancy and statistically are less likely to be able to connect with care after pregnancy. The second step then is to systematically screen those people for barriers to care. The third and very important step is to address those barriers. So, it's not all barriers to all care, but it's quite focused on helping people access specific services. So in this case, it would be after a hypertensive disorder of pregnancy, what would it take for you to be able to get to primary care and get, your heart health attended to under your screening, your counseling, and your management as recommended. And that's where it's really important to figure out what are the key barriers that we need to be screening for, and what are the interventions that can make a difference. And then the fourth step is follow-up. So this is not a sort of one and done situation. This is a longitudinal program where people really, receive frequent check-ins to ensure that their needs are being met and that they're able to access the services required. And it's a bit of a cycle where, people may have to be rescreened and provided with, repeat or additional services over time until they've received the care that they need.
So is this a person, a system, both? Who is providing these check-ins? Who is asking these questions? Who is kind of the helper? It's almost like an assistant, right?
Yeah.
Someone who can help you a little bit, get to where you need, figure things out and get to where you need to be, which is that office. So
Yeah.
Is it a person always, or is it a virtual thing?
It's a good question. It is a system. It is often also a person, but it doesn't have to be. So often patient navigation is embodied by an individual, and that is the patient navigator. But we don't have to be so narrow in our sort of conception of it. It can also be multiple people, a team, or a health system that serves these functions, maybe in different places or by different people. And you're right, some aspects of it could be virtual or even automated, if that was found to be effective.
And this is not this might be it sounds like it's a progressive idea, but it's not 100% new. It's already been done in some fields, right? And it's shown promising results. Can you talk a little bit about that?
Yeah, so it has really been most studied in oncology for helping cancer patients to access both to, go from like a positive screening test to a definitive diagnosis and then to treatment. And it has been shown to help people at every step along the cancer diagnosis and treatment pathway, both to receive more timely and effective care. And it also has been shown to significantly reduce inequities in cancer diagnosis and treatment. It has been there's so much evidence for it in oncology that it's now considered a best practice. And I think as of February of this year, it's reimbursable. So insurance companies, including Medicaid, will actually reimburse health systems for patient navigation services. So this is a huge step forward because no longer are you dependent on private grants or research funding to make these patient navigation programs real and sustainable. But it's now sort of like a codified part of cancer care. There's some sort of like emerging evidence that postpartum patient navigation can help people to attend the postpartum visit in obstetrics, but we don't yet have information on what it does for longer term postpartum care.
Mm-hmm. Well, that's a start. And you mentioned that it's codified now in cancer care. That is also the goal in primary care, right?
So yeah, I mean, my dream would be, if this actually, proves to be effective in a pilot randomized controlled trial at Boston Medical Center, then to be able to scale it and try it at different sites. And if it's working for postpartum populations in different settings, then the dream would be for this to become standard postpartum care, that everybody if not everybody who delivers a baby, then at least everybody who delivers a baby and is at high risk for poor outcomes postpartum has patient navigation support.
Yeah, I think it's really smart and wonderful, and I also think that it's obviously the RCT is going to happen in 2027, then more testing at other sites, and it'll take a while obviously, but hopefully this happens. And it seems realistic, we're not tackled in 2 years to get rid of racism, to get rid of all socioeconomic differences among us, family violence, whatever. Like, all of these things are involved in all of our health problems, right? But and that's why it sometimes feels so overwhelming to try to fix the system. But you're doing it here in a way that is, one patient navigator and one patient navigation system seems like a realistic way to kind of chip away at those really ingrained inequities in our society.
Yeah, it's this is a messy problem. It's complex. I think for every individual who doesn't connect with care, there are a multitude of reasons, and they're different from person to person. So while it would be nice to solve these bigger issues, patient navigation feels like something that can really provide, the multi-pronged, individualized care that people need. And we need it so urgently, while we work on those bigger, even further upstream issues. I do think, in building the evidence for patient navigation and investing in programs that provide much needed support to high-risk postpartum moms is extremely important.
Yeah. And in a email to me, you mentioned that Boston Medical Center is New England's largest safety net hospital. Is it important? Is that safety net part important? And especially in the context of what we're doing here or what you're doing with the patient navigation, what does that mean, safety net hospital?
Yeah, so a safety net hospital basically is, you can picture a safety net, like when all else fails, you have your safety net. Safety net hospitals have a mission and often like obligation to provide care to everybody, regardless of their ability to pay or their insurance. So, Boston is a city replete with renowned hospitals, but that doesn't mean that you can get the best care. If you don't have insurance or you have extremely high copays, you may find a lot of your options limited. Anybody with any insurance or no insurance can come to BMC. And I really love BMC's motto. It's exceptional care without exception. And that's really the essence of a safety net hospital. And it absolutely matters for this research question. Just to sort of paint the picture, not only is this a high volume obstetric hospital delivering anywhere between 2,500 and 2,900 babies a year, we have a much higher than average rate of hypertensive disorders of pregnancy. It's about 20% in our population. And our population is exceptionally diverse. About 70% of our patients identify as a person of color. Many of them don't speak English. Many of them are facing extraordinary barriers to care, not just language, but also issues with transportation, employment, housing. Right now, we're seeing a huge influx of Haitian immigrants, and they are, faced with really tremendous barriers to care. So I think not only is the need great at Boston Medical Center, but if we can come up with an intervention that works at BMC for our patients, I feel pretty confident that it would also be able to work somewhere else, just because the need and the sort of complexity is so great.
Really interesting. Two related questions to the BMC part of this. Number one, who pays for BMC to do all this wonderful work if it's not the patients and not the insurance companies? And number two, you mentioned that a lot of these women that you're targeting are not told, or in general, women with hypertensive disorders of pregnancy are not told to check in on their heart health in primary care, right? I'm guessing that you're doing that at BMC already, even though the RCT has not yet happened. I'm guessing since you have so many hypertensive disorders of pregnancy women there, the population is high. Your OBGYNs are, or maybe they're not, but I'm guessing that they're already doing the links in their head. They're telling these women, all right, make sure you see primary care doctor. In fact, Mara, even though I know you're not taking any more patients, maybe somebody else at Boston Medical Center is. So I'm guessing that the good work is already happening at BMC before your RCT because of this philosophy that the hospital has.
Yeah, two great questions. And I'm not going to have a really good answer for the how does the money work. I'm sort of glad that's not my job to figure out. I know, we
got to tell the rest of the country about this. It's fantastic. I mean, I'm sure that they exist in other states, but
we take all types of insurance. So when someone has insurance, the insurance company helps to pay for the care. When they don't have insurance, there is there's a part of the state budget every year that goes towards supporting public hospitals.
Yeah.
So, any deficits may be incurred by the hospital because of caring for people without insurance or an ability to pay is addressed by the state. And then, of course, we depend on, like many academic medical centers, we depend on research grants and private foundations and philanthropy to support a lot of our innovations and patient-centered care, especially if they're not reimbursable by insurance. That leads me to, part of the answer to your next question about, what does care for a patient with a hypertensive disorder of pregnancy at BMC look like right now. So one of my colleagues in OB actually did acquire private funding to be able to provide remote blood pressure cuffs to all of our patients with a hypertensive disorder of pregnancy or with increased risk for a hypertensive disorder of pregnancy postpartum. So that's really exciting. But things like this aren't necessarily sustainable, and so that's, that's why it'd be really nice to have these things become best practice or standard of care.
Yeah.
In terms of, what care or that transition looks like, I will say that yes, probably there is a heightened awareness at BMC relative to other places, relative awareness of the both the prevalence and the importance of hypertensive disorder of pregnancy and what they mean for a person's long-term health. That said, there is so much going on in pregnancy care, and there's so much going on in primary care. I can't guarantee that every provider remembers to mention this in care. And even if they do, I know for certain that every patient doesn't remember that. And so we have, conducted surveys and interviews with patients at Boston Medical Center, and it's been really interesting to hear from them, how little they recall of this, postpartum transition counseling. Just to give you a sense of the numbers. So we did a survey of postpartum patients at BMC. We asked them, would you like to connect with primary care in the postpartum year? And if so, when? 90% of them said that they would like to connect with primary care. And of those who had a complicated pregnancy, including a hypertensive disorder of pregnancy, in total, 60% wanted to have primary care within the first 3 months postpartum. Then we asked, what do you remember being told about when you should connect with primary care? And 50% recalled no mention of primary care. That's not to say that it didn't happen. It's just to say that there's total information overload, and we're not effectively communicating to these overwhelmed, sleep deprived, stressed out, distracted moms about what they need postpartum. So I think, it needs to go beyond just the communication in the visit. I think, there are some creative solutions around improving that communication. But again, this is a gap that could be filled by a patient navigator who really provides that individualized support, the reminders, and the information postpartum.
Yeah, because, you said that pregnancy is a very unique time in a woman's life, when she's more vulnerable to complications, but also when she is, quote, extremely motivated to become or stay healthy. So clearly these women were not lying when they said, we want to see someone in the next 3 months, but they also weren't lying when they said, we don't remember saying that.
Right. And if you're not being proactively reached out to by the health system, I mean, the last thing that you want is another doctor's visit. And I've heard this in interviews with patients, they care deeply about their health. And of course they want to be healthy. But at the same time, they just had a high risk pregnancy. They just delivered a baby. They're so happy not to have weekly or every other day monitoring, or to be on bed rest. And so they're not looking for trouble, I would say. They're not necessarily seeking out additional visits, especially if the recommendation for visits is not clear. So I think that's where having, again, a person embedded in the health system who is looking out for the patient, attending to their healthcare needs, but also, taking this holistic view of, how is your life going? What is it like being a new mom? And how can we help the healthcare that you need fit into the life that you have right now?
Wonderfully put. Last question for you, Mara. Your overarching passion is health equity. That's clear. That was made clear during this recording. You told me in an email that becoming a primary care doctor, quote, humbled you to realize that so many barriers to long-term health come long before a clinical visit is booked or missed. And it has to do with so much more. Can you talk about that and your personal experience in this space as a clinician on the other end of, for example, a Haitian woman who, like you said, has so many challenges to get there, or, facing a lot of things like, what has this been like for you? And how has this kind of what is the evolution that you've undergone as a woman?
Well, yeah, I mean, I think I told you how I came into this research as a mom, as a person who was experiencing the postpartum transition, and how surprising, wonderful, and like scary it is. And then I wanted to find a way to make a difference in my work, and I really found my foothold then as a primary care doctor. So I was like, okay, I have the skills of a primary care doctor. I'm well positioned in the health system, be able to address chronic disease and prevent chronic disease in primary care visits. So that was my initial focus, and I thought a lot about best practices in primary care for the high risk postpartum patient. What kind of counseling do they need? What kind of treatment, et cetera. But then I think, the sort of the journey continued, and I started to realize that a lot of the people that I needed to be having those visits with weren't ever getting to primary care. And if I didn't think about access to healthcare, I wasn't ever going to be able to implement my postpartum checklist. So that's become the focus of my research, is really thinking about access to care.
That's Dr. Murray Horwitz. She is a primary care physician at Boston Medical Center and an assistant professor of medicine at Boston University, known as BU around here. Mara Elizabeth, thank you for coming on the show, and congratulations again on your 2024 Basil O'Connor Starter Scholar Research Awards. No pressure, only some very, impressive careers that have walked this journey before you. And I know that you will fit those footsteps beautifully. We await the results of your efforts and your research and your interventions with bated breath. Thank you for coming on the show.
Thanks so much.
Thank you.